Good afternoon, everybody. I'd like to welcome you to this event, which is being held under the auspices of the School of Life and Medical Sciences at the University of Hertfordshire. My name is Leslie Titcombe and I'm a governor of the university, and I'm very pleased to be introducing today's event. This is part of the university's LGBT History Month. My main role today is to introduce the speakers and the panelists, and then during the event the chat will be open so that you can ask your questions, and these will be brought to the attention of the panelists when we get there. Today we're very pleased to welcome as our speaker Dr. Jaime García-Iglesias, who's a research fellow in the School of Life and Medical Sciences and a Mildred Baxter postdoctoral fellow. And we're also joined for the panel session by Dr. Shivani Sharma and Dr. Maurice Nagington. Shivani is head of the psychology group here at the School of Life and Medical Sciences and is the executive lead for equality, diversity and widening participation. And Maurice is a lecturer at the University of Manchester, and his research has focused on two areas: palliative care and cancer, and more recently on gay men's health. So, without more ado, I'm going to hand over to Jaime.
Hello, hello everyone. I'm Jaime, and I'm very honored to be here today to talk to you about AIDS, COVID-19, and the politics of memory. So I'm going to try to share my screen now. Can you, some of you, confirm whether you can see my screen?
Yeah. All good.
And can you see the slides changing?
Yep.
Okay, good. So this is going to be today's presentation, lest we forget AIDS, COVID-19, and the politics of memory. And before we start, I need to explain what my position is. So I'm a sociologist by training. I've been writing about HIV and about how people make sense of it in their everyday lives for a long time now. And I've been very interested in memory. We're leading a project with people from Manchester about memories of the gay village. And I'm also co-editing a special issue with Maurice Nagington about the memories of AIDS and how they influence our COVID-19 perceptions. So when COVID came along and there were so many things to talk about in terms of COVID and HIV, I kind of had a field day. And this presentation is going to move somewhere between the US and the UK context. I will try to keep it focused on the UK as much as possible, but there will be some mentions to the US context. You have my Twitter there if you have any questions or follow-ups after. So the current moment, since appearing in November 2019, COVID has been a major change to our society. So much so that, for example, UN Secretary General Antonio Guterres said that it was the greatest test since World War II. Bill Gates said it was the first modern pandemic. And a philosopher that I really like, Paul B. Preciado, asked whether the virus made us rethink under what conditions and in which ways life would be worth living. Both the virus and the measures put in place to hold the spread, such as lockdowns and confinement. So it has changed profoundly our society and how we relate. And very frequently, when talking about COVID-19, we return to talking about the flu pandemic of 1918, called the Spanish flu. Had nothing to do with the Spanish, but that's a whole other fight. And we have all these articles in places like The Guardian and CNN reminding us that the world has gone through this horrible pandemic before and that they survived. But in fact, there has been a much more recent and perhaps more troubling pandemic, one that is still ongoing for many communities and many countries, which is the AIDS crisis caused by HIV. And that's going to be today's focus. So there has been some reporting on the AIDS crisis and how it relates to COVID-19. So writing about, for example, Andrew Holleran's work, poet and author Garth Greenwell has said that he had felt an eerie affective familiarity between AIDS and COVID-19 in terms of governmental failings, uncertainty, contradictory information about risk and who was at risk and who wasn't, about the obituaries and there's so many people who are dying. Similarly, Katie Butler, writing for the Los Angeles Times, said that both the AIDS epidemic and COVID-19 had many resemblances. And I really like this heading by Associated Press for US News, which reads, COVID-19 and the AIDS crisis, New York City gays see parallels and contrast. And I wonder, is it only New York City gays who see parallels and contrasts? Is it only people from New York? Is it only gay people? What does this headline tell us about who and why remembers the AIDS crisis when presented with COVID-19? And that's going to be the question today. How do we remember AIDS? Who remembers AIDS? And why is it so? But before we start, obviously we have to do some basics. And by no means am I a doctor or an expert in any of these kind of ideological aspects of HIV, but this is a very basic kind of intro to HIV. So HIV is a human immunodeficiency virus, and it is a retrovirus that attacks the human immune system. The virus can be transmitted through a number of ways. For example, sharing injecting equipment that has been contaminated, blood, semen, and a number of other bodily fluids, poorly cleaned tattoo equipment, unprotected sex during childbirth. But HIV cannot be transmitted through sweat, through tears, or through saliva. So kissing, touching, that there's no risk in that. If HIV is left without treatment, it will slowly weaken the immune system and eventually progress to what we call AIDS, a stage at which the body immune system is so weakened that it's unable to fight off usual infections and develops a certain number of conditions, such as specific types of pneumonia or of cancer, that are unique to bodies that have such a low immune system. And that's what we call the acquired immunodeficiency syndrome, or AIDS. So you can get HIV, but you cannot get AIDS. AIDS is a product of HIV that has not been treated. While HIV is not curable, it is very much treatable. And today there are a number of very effective medications that can stave off the progress of HIV and very much make those people who are living with HIV have normal life expectancies with very few side effects, if any. At the same time, there are also ways to prevent it, such as condoms, but also PrEP, or pre-exposure prophylaxis, which prevents people from getting HIV. Interestingly, although many times we think about AIDS as a disease of the past or a crisis of the past, and that's in a way how we're going to frame it in this presentation, it is worth noting that today there are 38 million people worldwide living with HIV. 26 million of them were on treatment, which means that as many as 12 million people were not on treatment and therefore very likely to develop AIDS and die. In 2019 alone, 1.7 million people became newly infected with HIV, and almost 700,000 people died from AIDS. So in the UK, or in the world, we should say, the story of HIV starts in June 1981, when the CDC, the Center for Disease Control in the United States, reports 5 young gay men who had died in Los Angeles, and they were previously healthy, so it wasn't very clear why they had died and why they had developed specific types of pneumonia. Later that year, the first AIDS death is recorded on the UK soil in October 1981, and it will take 2 years for those deaths that initially are very unclear to be identified as caused by HIV. It is in 1983 that the virus of HIV is linked for the first time to AIDS as the cause of AIDS. So if you compare that with how quickly we were able to identify COVID-19 as, well, SARS-CoV-19 as the cause of COVID-19, you have 2 whole years of wait time for HIV to be identified. The early AIDS epidemic in the UK is kind of framed in 3 different groups. First of all, we have gay men, mostly in London, but also in other urban areas such as Brighton and Manchester, who are contracting HIV through sexual intercourse. We also have people with hemophilia who contracted HIV through blood donations that were purchased by the UK government and the NHS in US soil, transferred to the UK, not properly treated, and therefore contained HIV. And those people who were receiving them as part of their hemophilia treatment also contracted HIV. And then we also have heroin intravenous drug users, particularly in Scotland, places like Glasgow and Edinburgh, who are contracting it at very high rates. In the UK, the period that goes from 1981 with the first death to 1986 or so is what Berwick and Strong call a period of increasing awareness. So society starts to realize, and politicians start to realize, that this is something very much happening. There is the development of activist organizations, a degree of working between these organizations, medical doctors and medical professionals, and politicians to develop campaigns and activisms, but it remains very much a awareness, the sense of an impending crisis, but we're not yet in the crisis. That changes between 1986 and 1985. So in 1985, Rock Hudson dies. He was a very popular Hollywood star, heterosexual, and he dies from AIDS. And at the same time, or a year later, Princess Diana attends and inaugurates the Middlesex AIDS wards and touches, shakes hands and hugs the patients with AIDS that are in that specific ward in Middlesex Hospital. And these two events kind of are the signifier of a larger change in the perception of AIDS, from something that we are aware is happening to something that becomes a major crisis in the UK politics. It becomes a national emergency, and the period between 1986, 1987, and maybe going into 1988 is what we call the period of national emergency. And that period is inaugurated by the release in 1986 of a campaign of announcements by the UK government called AIDS Don't Die of Ignorance. This campaign was designed with the advice of activists and scientists. It was designed in particular to avoid stigmatizing any group for AIDS. If you look at this poster and the advertisements that were mailed to 23 million households and put on TV and on the radio, the emphasis is on risk acts and practices, and not so much on risk populations or groups. The focus is what are the things that you can do that can get you to contract HIV, and not so much whether certain groups are more likely to get it or not. This was, in my opinion, and although there has been some debate about it, this was very much needed. Since the very early years of AIDS, both in the US but also in the UK, the crisis was marked by profound homophobia. This homophobia, for example, was most notably evidenced in the development of the term innocent victims. So I said that in the initial years of AIDS, there were three groups of victims: heroin users, gay men, and hemophilia patients. And it was those hemophilic patients who were named as innocent victims. Assuming that these people were innocent of contracting HIV immediately leads to the assumption that there are certain groups that are not so innocent, meaning that there are groups who deserve to get HIV. So this idea of innocent victims comes to signify just how homophobic the reactions to AIDS were during the 80s and 90s, and still perhaps today. For example, or a further example of this, and this is one I particularly like, is James Anderton, who was the chief police constable of Manchester in 1986. He said that people living with HIV were swirling around in a cesspit of their own making. Not only was he not chastised by Prime Minister Thatcher, he was allowed to retire as chief police officer. He was awarded an OBE. He is still very much alive, and there you have it in 2018, inaugurating the Police Museum of Manchester. And that's the person who said that people living with HIV were swirling around in a cesspit of their own making. So something that's very appealing about studying the AIDS crisis is that it seems to be so far removed from us, but in reality, many of the key players who were at the time making the most important decisions are still alive. It is also important to say that by the end of 1988, more than 10,000 people had HIV in the UK, more than 1,500 had died from AIDS. And the fears that were had up until this point, that AIDS would become a worldwide epidemic, very much became true. They became true because by 1995, the leading cause of death for Americans aged 25 to 44 was AIDS. And still then, more than 10 years later, there were no effective treatments and no reliable treatments either. The few that were available had major side effects, were not that effective, and essentially were just a different way of killing you. It was only in 1996 that ART, the first effective medication, was announced. It still had severe side effects, but it was effective at delaying HIV from becoming AIDS and for allowing people to continue living. From 1996 onwards, we see a sharp decline in the number of deaths, but also a very slow development and progress and rollout of this medication across the UK. So besides the medical or biomedical crisis, there was also a cultural crisis. These groups of people, from heroin users to gay men to lesbian women, all these people were suddenly felt that they were being abandoned by their government, who didn't care that much about them because they were not perceived to be as innocent victims. One of the collectives that most signified this cultural response is ACT UP, which stands for AIDS Coalition to Unleash Power. It was founded in the United States, but then had chapters in the UK and in France and in other countries. It was a grassroots campaign to mobilize against governmental inaction or improper action, against the stigma. It called out politicians, it provided research, it provided leaflets with public health information and prevention strategies, support groups, etc. Their most famous poster is this one called Silence Equals Death, and that poster was designed in 1987. The pink triangle is supposed to be a reminiscence of the pink triangle that homosexual people would have to wear in concentration camps in Nazi Germany. And the slogan Silence Equals Death kinda is a subtle reminder that if the deaths of these people are not being acknowledged, if their needs are not being met, if they are not being considered, essentially it's not only that they are dying biomedically, it's also that they are socially dying. It's that their deaths are not going to be remembered, they are not really interesting for society, they are not worth it. And it was thanks to posters like this and many other actions that AIDS kinda became a cultural terrain in which there were these opposing narratives that was much more homophobic and that which was much more interested in providing effective information and treatment. People were dying. In many cases, they were dying alone. They were dying without their families who had repudiated them. They were dying without their loved ones. They were dying in pain, and they were dying horrible deaths. This is the image of David Kirby, 33 years old. It was taken by Theresa Frere and made the cover of Life, and afterwards made the cover of a campaign by Benetton. But it's very much a poignant image of just how pressing the crisis was at the time. That is why it's so important. Images like this by Princess Diana, who not only visited AIDS wards and talked with patients and with doctors, she touched them, she shook their hands, she sat in their beds, showing people that AIDS is a virus, but it's also a lot of a stigma, and therefore we can't fight that stigma, even if at the time they couldn't fight the virus that much. It is difficult, anyway, even with pictures, to explain the magnitude of the crisis that was happening at the time. So I'm going to now bring you a quote from a participant of a research I did a few years ago. And this is Josh. Josh is 52 years old. He was 18 in 1984, and he was living in Chicago. And he says, "It was almost 84. I was 18 and I got a boyfriend. About a year and 2 months later, he was dead. So that's when, you know, by the time in 85, all of his friends started to get AIDS. So for 2 years, up until 1987, my life was people dying in my arms and taking care of them. And the problem of taking care of them, there's nothing to do. They're dying, and some of them had a horrible death. Most died in my apartment. All I remember from these 3 years, and I still was going to school. All I remember was it was so weird. It was taking care, taking care, taking care, and that push, push, push forward. I remember when Sean died in 1987. He was the last one because all the others had already died. I had to go into withdrawal and find out what to do. Use the syringe, take the pills. Those took me a while to take that off, the nursing mindset. And here you can see an 18-year-old man whose boyfriend dies, all of his friends die, and there's nothing to do, not only because these people were ostracized by society, but also because there's no treatment, there is no cure. So it's a sense of major crisis, a major change in how these people perceive the world. And this is what Sarah Schulman calls the haunting of memory. And this is a book I have to say thanks to a colleague of mine at Edinburgh who kind of introduced me to this book. And Sarah Schulman, I have put a picture there because I think it's nice to sometimes see the face of theorists and say that we're not always, they're not always sad, they're sometimes smiling. So Sarah Schulman says that AIDS was and is a phenomenon so broad and vast as to permanently transform the experience of being a person in the world. And if you look at this quote, it is very reminiscent of the quote by Preciado at the beginning that said that COVID kind of made us consider under what conditions life was worth living. But most importantly, Schumann argues that the silence that surrounded AIDS deaths was disallowed. The grief that followed it was disallowed. She says, the disallowed grief of 20 years of AIDS was replaced by ritualized and institutionalized mourning of the acceptable death. In this way, 9/11 is a gentrification of AIDS, the replacement of deaths that don't matter with deaths that do. So what she's coming down to say is, as the AIDS crisis was coming to an end, treatment became available, people were no longer dying in the globalized north, in most people who could afford treatment. There was a time of reckoning, and the time was right to have a reckoning of what had been done poorly and not so poorly, mourn those who have died, have an exercise of national, across the world, national and community memory, and kind of come to terms with that profound crisis that AIDS was. But right then, in 2001, 9/11 happened. And as 9/11 happens, the governments and politicians took hold of that event to create a fake sense of national unity and gentrify that memory, avoid that coming to terms with the crisis, and instead generate a fake sense of unity and national narratives. And this is very interesting because if you look, for example, at the monuments that exist in the United States, but also probably in the UK for other events, here on the right, you can see different 9/11 monuments. Almost every town, no matter how small it is in the US, has a monument to 9/11. But there's only one monument created for AIDS victims, and it's the AIDS Names Memory Quilt. It was created by activists, and essentially it meant that you would embroider a piece of fabric when somebody close to you died. You would mail it to them, and then they would create this massive quilt. It's the largest piece of folk art in the world, and they would put it all together as this massive quilt to remember those who have died. But this is not a national monument to death. This was created by activists because there was an absence of national coming to terms with the memories of the AIDS crisis. It is worth noting that there has been a recent uptake of or a recent revival of the AIDS crisis. So you can see, for example, 120 BPM by Robert Campillo, which is a movie about ACT UP in France. That was Bayer's Club, It's a Scene, After Silence, and a few other books and movies have been happening. But what is perhaps most interesting of this is that these movies and books do not talk about the current situation of HIV, they do not talk about the thousands of people dying every year of AIDS in Africa, even today. They go back to that moment, to the 80s and the early 90s. They go back to the moment of the AIDS crisis in the globalized North. There is a sense of haunting, as if the AIDS crisis was something that's always in the back of our minds, something always already not available to talk about, not ready for discussion and for engagement, something in the back of every other narrative. The foreclosure of laws, the foreclosure of mourning, led to a sense of haunting, particularly for LGBT communities and gay communities. And this sense of haunting still pervades the cultural production about HIV by reminiscent all the time to that AIDS crisis of the 80s. Worth noting as well, AIDS remains a crisis for many communities that are not in the globalized north, like trans people, African American men in the south of the US, etc. But I think it's time now to return to the present. And perhaps the most interesting aspect here is what are the differences and the similarities between AIDS and COVID-19? And we've talked about them so far, and we've talked about how any perception of COVID-19 is haunted by the memory of the AIDS crisis. But what are the practical differences and similarities between both viruses and both crises? And the first one, and for me the starkest one, is a difference in the groups that have been seen as affected. And obviously both viruses can affect anyone, they don't discriminate, but the groups that were early identified with AIDS were gay men. You have pictures there of, for example, Stephen Gideon images of the ward, and heroin drug users. You have an image there of Tommy from Trainspotting, which is a very good movie, and includes a couple interesting storylines about HIV. As opposed to these images of people who are identified with AIDS, we have the images of people who are identified with COVID-19 through many ways. HIV still remains very much transmitted through sexual intercourse and intravenous drug use. But there are also many similarities, I think, between the AIDS crisis and COVID-19. And perhaps the most stunning one is how both viruses were used to mobilize pre-existing agendas and pre-existing racism and homophobia. So in the very early days, AIDS was used to stigmatize gay men. You have these headlines from Gays in Fear, My Doomed Gay Plague, Britain threatened by the gay virus plague. And this is very similar to how COVID was used to mobilize anti-Asian agendas and racist agendas. Trump repeatedly called it the Chinese virus. There was a spike in racist attacks in the UK. And these kind of similarities have been picked up by artists as well. So for example, ACT UP published this on their Instagram. And on the left, you have an image of David Wunarovich. That's a picture by him that says, if I die of AIDS, forget burial. Just drop my body on the steps of the FDA. The FDA was the Federal Drug Administration. It was the organization in charge of managing trials for medicines, delivering or approval to medications, etc. And it was blamed at the time for slowing down the process and putting many bureaucratic barriers to actually delivering treatments to people. And that's kind of a complaint that you see in that leather jacket. On the right side, you see an image created by Housing Works in partnership with ACT UP that says, if I die of COVID-19, forget burial, drop my body on the steps of Mar-a-Lago, which comes to signify just how government inaction has been prevalent in both crises and in both pandemics, and how government inaction is very much the one to blame. So in the face of individuality, what we need to highlight, I think, is the structural issues that underlie these pandemics, issues like government responses. HIV was ignored because it was the disease of the other, of the outcast. COVID-19 has been shown to disproportionately affect people who have unstable housing, who are precariously employed, who have no health insurance, who are migrants, or who are in the prison system. So there are many structural similarities in how both viruses have affected those that are most vulnerable. And now I'm gonna do a pan on the movie, but I think we should return to the future and perhaps think, what happens once this is over? Are we going to be forever haunted by the specter of a COVID-19 death and a COVID-19 pandemic? I don't think so. COVID has been remembered and is being remembered, and it is being grieved and mourned extensively over the past few months and probably over the next few years. It will be addressed at the national scale we will be traumatized for sure, but probably not haunted, because we will have the space and the time to actually acknowledge and think and come to terms with what happened to us. There will be monuments and political speeches and museums, things like never happened with HIV. So lessons from the pandemic. There are still many things that we can learn about COVID-19 and HIV, despite the differences. The first of them is that we're not all in this together, and this may be a difficult statement, but I think it's very much true. Even today, HIV disproportionately affects Black and trans communities, homeless people, trans women, etc. There are also ones that are less likely to be able to access healthcare and treatment if they contract the virus. By saying that we are all in this together, what we are erasing is their particular experiences of vulnerability and discrimination. Similarly, in 2020, we are not all in this together with COVID. Research has shown that this disproportionately affects communities that have already been impacted by health inequalities, white, rural, poor communities, Black folk, undocumented people, people in precarious employment. Rather than being a great equalizer, COVID-19 has deepened and highlighted the profound inequalities that divide us. And this is an image from the Spanish lockdown, and the streets in Madrid are empty because it is a national mandated lockdown, but there's still a driver from Globo, which is similar to Uber Eats delivering food, which highlights just how vulnerable certain people are, not because of their own actions, but because of the structures that keep them in those positions. Therefore, talking about individual responsibility ignores that there are many people who cannot socially distance because they may live in crowded housing, who cannot afford new masks because they may not have money for it, who cannot afford to self-isolate if they have been in contact because they cannot afford losing the earnings from just one day of work, or because they cannot afford going to the doctor if they're sick because they may be kicked out of the country. It has also shown that the stigma and prejudice is alive and well. It has reinvigorated that stigma and that prejudice, in fact. The Chinese virus is just the latest reinforcement of racism towards the East and towards China, in the same way that COVID has also served to mobilize homophobic agendas in South Korea. On the upside, this virus, I think, has shown us that memory is really important, and that we need to be responsible for our own memory, that we must hold governments accountable for their actions and their lack of action, and that leaders should be questioned on their decisions. Above all, I think, AIDS has shown us, and COVID has reinforced that message, that memory is political. It is a device used to erase people's lives and people's deaths, to generate narratives about who we are, who we could be, who we are worth being, and who is not worth of being. As we move towards a post-pandemic future now with the vaccines, I encourage you not to let other people dictate your memory, or not let other people remember for you. Memory is a political tool. We need to remember the fake news. We need to remember the inequality. We need to remember the poorly put together plans and lockdowns. We need to remember and act accordingly, because that memory is what we lack of the AIDS crisis. Thank you.
Thank you very much, Jaime. That's great. Now, if we have Shivani and Maurice with us, then they will now come onto the panel. I don't think we have any questions through as yet, so perhaps I could ask Maurice if he would like to comment on what Jaime said, and then we'll see if some questions come through.
Yeah, I was making sort of lots of notes as we were going through. I think the thing I'm most interested in talking about is this idea that we're all in it together. So kind of what you finished on, Jaime. And I think that's got lots of resonances with HIV and particularly in relation to this idea of PrEP. So there's been a very long battle of, at least 6 or 7 years, really, in getting the HIV prevention drug PrEP onto the NHS. Now, we won't ever really know for another 20 or 30 years when those documents are released exactly what the conversations were, but it's hard to kind of tease out the government thinking in regards to this. But I am sort of reminded that there seems to be in certain quarters of the Conservative government, a sort of ideologically relaxed nature to public health and the construction of the public versus the construction of the individual. And I think what we've seen with COVID is that public health budgets, way before COVID hit, were in most cases cut. Partly that was due to council budget cuts, but it certainly wasn't prioritised. And centrally there were many double-digit cuts as well. And I think the government rather relied on individuals taking up the mantle of public health. So with regards to PrEP, I think the government might, again, slight conjecture, but I think the government was really quite relaxed that he was privately sourcing it. And the amount of uptake for PrEP that was allowed through the impact trial vastly outstripped supply. And I think that's what shows us. Is we then get comments from people like Graham Brady in relation to COVID, where he says individuals should be, I'm not quoting him, but he kind of vaguely said that individuals should be empowered to protect others against COVID. And again, it's this idea that individuals can take on the role of public health. And for me, that's a great misunderstanding of the role of the state in public health. And I think we've still got a lot to learn in this country about how the state does have a big role in ensuring things like obesity is tackled, air quality is tackled, and we know that areas where those are problems, air quality, obesity, COVID has hit far harder. So I think we're still a long way from learning the lessons of HIV and actually getting our head around what it means to be all in this together and where the state has a role in playing with bringing things all together and protecting individuals. So those are some of my kind of introductory thoughts.
Shivani, do you want to come in here? We're just trying to, there has been a question posted. We are just trying to locate it. Shivani, is there anything you want to say in the meantime?
I have the question.
You have the question.
Excellent. Do you want to read it out?
I think Shivani can introduce herself and her thoughts on the
Yeah, I guess firstly I'd just like to say thank you to Jaime for a really thought-provoking discussion and presentation there. It just goes to show what a post-meeting discussion can lead to, and actually the idea for today's talk came from us sharing the parallels of our work, so Jaime's work in the field of HIV and AIDS and my own interest in health inequalities and what we've seen as the pandemic progresses, as the communities who are being stigmatized, those who are most vulnerable to both the direct as well as the indirect effect of the pandemic, and how there seems to be some surprise, frustration, anger about this, as opposed to actually active anticipation that those who experience the most disadvantage in communities outside of a pandemic, of course, will go on to experience the worst direct and indirect impact as the pandemic progresses. Crises such as this very rarely affect all people in society in the same ways, and they just simply act to reinforce the structural inequalities that are there. Most of my work has focused on minority ethnic communities, so many of the messages in Jaime's talk, it's fascinating how they align, so the same kind of how language is used, so the confusion in the messaging around COVID-19 at the beginning, wear a mask, don't wear a mask, go to school, don't go to school. some politicians using language that might explain a blame narrative, for example, that minority ethnic communities are causing or contributing to higher transmission, etc. And then, of course, how we empower all people to be able to actively use the guidance and the advice that is there to keep them safe, recognizing that often there is a social gradient to that. So based on these discussions, we really came up with the idea of today's talk and the panel discussion. But my work focuses particularly on transplantation. So something, you know, that is in a health setting completely different, but in many ways, I recognise that there is, you know, in a crisis like this, health services have to reconfigure, they have to change the way they're doing things, but there are, of course, unintended consequences of that. And you can make a decision to accept this or to actively plan to repair and rebuild a stronger future. So it's really about the how have we not learnt these lessons from the past, and we're continuing to, you know, see a lag in some of the policies, practices that are designed to safeguard people actually just being delayed, deferred. So how do we rebuild in a way that meaningfully addresses health inequities, health inequalities, as opposed to constantly leaves this as a political promise for future? So that's the kind of stance that I'm bringing to the topic.
Excellent. Thank you, Shivani. We've found the question now, which is good news. So there's a couple come in, which is great. So should I read these out just for the benefit of everyone? So first question, I'm struck by the coverage of those, including senior politicians, who've refused to wear face coverings to minimise the risk of transmitting or acquiring COVID-19 and have worn this almost as a badge of honour. And there's a libertarian dimension to this too. And how these same politicians would have responded to gay men at the height of AIDS in the global North developed countries had they publicly declared their refusal to practice safer sex. There's a very different narrative of individual and social responsibility in the two pandemics. And the questioner, who is Matthew Waite, would appreciate your comments, please.
Yeah, thank you for the question. Probably Shivani and Maurice have a different take on this. But I think this is not necessarily a hypothetical question. We know that some of those people who were responding in certain ways to the AIDS crisis, like Dr. Fox in the US, are still alive and responding to COVID-19. I think for me, when I talk about individual responsibility, such as the case here of whether you refuse or accept to wear masks, or whether you refuse or accept to have safer sex, it comes down to it not being exclusive to government action. Both things are not necessarily exclusive. They occur together, and I think that in Larry Kramer's The Normal Heart, there are a couple excerpts in which the argument is very clearly made that yes, we have to have safer sex, but we also have to have the government take these actions that we need at a national level. And unless the government does that, our individuals' actions are not that useful or that effective. And I think in both cases, or what links them together, is that the virus and the measures put in place have been used to mobilize pre-existing agendas by those politicians. So, for example, in the UK, surprisingly, the AIDS crisis facilitated the development of a less criminalized drug policy in Scotland, for example. It is something that probably nobody expected at the time, but the AIDS crisis and a number of people getting HIV from drug use in Scotland facilitated the introduction of this policy. Whereas, for example, COVID-19 has facilitated the reduction of certain civil rights. It has justified appalling treatment to prisoners across the UK and across the world. So I think it's not so much whether any of these discourses are new, but what discourse was there before that has been mobilized and done through these viruses.
Boris, do you want to come in?
Yeah, I suppose. I think the question is very astute in their noting of this libertarian approach to certain fairly easy public health measures like wearing a mask. But of course, if you're going to follow a libertarian ideology, what a lot of people won't like is the logical conclusion of that is, well, you would pay for your own healthcare. And even some of the wealthiest groups who would kind of propose that, their budgets would very quickly run out if they had to pay for their own intensive care work and all the healthcare that comes from that. So it very often feels like a very myopic, short-sighted and ignorant way of understanding how health and society actually functions. That if you are one of the unlucky ones to need that level of healthcare, which costs thousands of pounds a day, then you will get it in the UK. So obviously there's always this balance between the individual and society, but these people who argue those extreme libertarian positions, in my view, really don't want to take the responsibility on. That's right.
Thank you. Shivani.
I think this brings me back to and since he's the one that's asked the question, I can actually say this, to a conversation I had with Matthew, who's posed the question about Boris Johnson has COVID-19 and is painted as a national hero, but if he was a black man with HIV, what would that narrative look like? So I think there is something in here about, firstly, our own perceptions of risk and how much we feel that a particular condition applies to all of us equally, but also then something about the language that is used around the different conditions and how we relate to that. So what really interests me is how COVID-19 is almost akin to a war. It's a humanitarian struggle, but was that same language there, and did so many people relate to it in the same way in relation to HIV and AIDS? Most likely not. So that politicizing of how the language is used as well, I think, really makes for whether an individual is stigmatized or painted as, a national hero. So that would be my response into that particular question.
And it probably comes down as well to the early groups that are identified with the virus. And I must say that Shivani and I had the conversation as to whether this talk should be named "What if Boris had HIV?" and we thought better not. But it's a very good analogy, I would say.
Okay, let's move on to the next question, which is from Connor Howard, and I'm going to come to Shivani first on this one. Could you share your thoughts on how science has become very political within even the general public during COVID? Are there comparisons, do you think, with the AIDS epidemic, and is there anything that we can learn from this?
I think that the interesting thing is I'm currently doing a project with students actually looking at risk perceptions. The interesting thing to me about the science is how we assume that people understand it and actually they don't, and it's being used as a way to create more fear as opposed to genuinely empowering individuals to act. So even if you think to the first national lockdown and the speech that was given by Boris Johnson, for example, I was sitting there quite inspired, like, yes, we're going into this, we're going to stick to the rules, we're going to do this. And my husband is sitting next to me as a university graduate himself saying, what on earth is an R value? So even at that level, I think the science is being communicated at a level that is not what your average lay individual can engage with. So coming back to this question, it's quite complex to answer when actually most people, I don't think, have been able to follow the basic science behind this, or there are so many different viewpoints out there that you can access through Instagram, Twitter, etc., so-called fake news that is also leading to this vaccine hesitancy, etc. I don't see from my conversations with people living in India, for example, the same degree of, oh, if there's a vaccine available to me, I'm not going to have it. It's kind of like, I can't wait until it's available to me. Yet sitting here in the UK, this is a very common discussion that we're having, is how do you reach minority communities? So I think what the science has actually forgotten is its own history. Why is it that there is a mistrust in health services, in healthcare, and actually vaccines in particular for example, Black heritage communities, if you track back a number of years to what trials have actually done to create that mistrust. And I think any conversation around science in relation to COVID-19 also has to address this, so that we get better at building this trust within communities and can share the right messages and make sure that they're actually delivered by the right messengers, not just out there in the ether for people to happen to access themselves.
Thank you. Maurice? Maurice, you're on mute.
Okay. Yeah, I think maybe similar to yourself, Shivani. I live in a in a health department. I live in a bubble of people with mostly PhDs and masters who intuitively understand this stuff. And I think one of the things that has caught a lot of people out is the lack of uptake of the vaccine from healthcare workers, particularly social care workers. And I think there's also a class politics going on where I've seen very little good scholarship or understanding of why people who will predominantly work in care work, often working class backgrounds, predominantly women as well, and why there is such a low uptake. You seem to be 50–60%, and they were in the top priority groups, yet they would have seen in a lot of cases the deaths of people from COVID. In many cases, a dozen or so, and have to be counting. So I think maybe that really caught people off guard with the class politics of it as well. And I've been very little fun about that.
I would observe also, as the token arts graduate here today, the main thing I would observe, and having lived, as a student and then working in London through the 1980s, is just the level of data that is now available to us constantly in a way that certainly wasn't the case in the 1980s. That is certainly a factor. So, everybody now can express their view on the basis of probably a bit of misunderstood data. Jaime, before I come to you, I'm just going to read out the third question as well, because we can tie this in, and we're coming towards the end of our session. So this is an anonymous question that asks, do you think that the government / medical community realises that they should be deploying the lessons learned from the HIV / AIDS crisis in response to COVID? Do you think, has the comparison been understood more widely?
Yeah, that's a fantastic reflection, Leslie, because I was actually going to say the same, that data doesn't equal science, and data has to be made sense out of. So we may have lots of data, but if we don't understand the inequalities that underlie the data and the traditions and the histories that are behind the data, we're not able to make sense of it. So I think for COVID, there has been lots of data, but not so much science. And not so much explanation to the public about what this data means and what it does not mean, and what it can say and cannot say at this stage. But I think, regards to the last question, I don't think there has been that much learning. And there's a book very recently published about the experiences of doctors during the AIDS crisis that explains how HIV medicine and HIV experts were kind of siloed and isolated from other expertise in healthcare, and that probably has played a role here. Many of the lessons about involving people in their care.
Okay, I found this on the web for medicine.
Many, sorry. Many of the lessons about involving people on their care and making sure that the community was involved in designing and developing the tools needed to prevention has not been there, and that has led to some awful prevention interventions, like these slogans of the UK government that ask you to watch out for a virus that really you cannot see. So I don't think it has been learned that much, and that probably comes down to it has not been remembered. There is no memory of AIDS, at least at the social level, and that explains, I hope, a lot.
Shivani, any final thoughts from you?
I think the key point for me is really about this integration and working with the very communities that you are trying to reach. And I think that is a lesson that could easily be translated in future if we really want to take seriously, you know, recommendations that are emerging in Public Health England reports, etc. Some of them you do kind of have to wonder, did you need to get a think tank together to tell you this, that people living in crowded accommodation are going to be more likely, etc. So that comes down to Jamie's point about the science and the data and what is it telling you. But yeah, I think that working with communities and really thinking about who the messengers and what language is appropriate for different communities will help us be better prepared for future threats, because I very much doubt that this is going to be the only pandemic of our time, but definitely we can be better prepared to manage the next big challenge.
Thank you. Maurice?
Yeah, I think that's an extent. Just thinking about the public face of the pandemic has very much been led either by politicians or medical scientists. You've seen nothing of the chief nurse, certainly in England, and you've seen absolutely nothing of social scientists right up at the front on television, standing with the politicians to help people understand public health messaging. They've been there on kind of, Good Morning TV and stuff like that, but they haven't been given the same prominence and understanding. And medics are great, but they have a particular, as we discussed, a kind of understanding of the world, maybe kind of slightly bubbled understanding of the world, and we just have not seen the social sciences, psychological sciences, or any of the arts and humanities given prominence that they need. And I think it was before the pandemic started. I can't remember which minister it was, but they hadn't even heard of a Michael Marmot report. And you go, huge problem in the phrasing of public health when government ministers haven't even heard of one of the generation's most talented and prominent public health people in the world, quite frankly. So I think there has been a problem with that, of how we framed it to the public.
Thank you. I think that's really brought us to the end of our time together. I'd like to thank Shivani and Maurice for their contributions to the panel, and particularly thank Jaime for his excellent and really kind of thought-provoking presentation for us as part of this LGBT History Month, which I think is so important. It's been an excellent event. I'd like to thank those who've submitted questions. I'd also like to apologise to those who've had a few technical difficulties in getting into the session. I hope you made it in eventually, and we're very glad to have had you with us. But for the moment, thank you very much from the School of Life Sciences at the University of Hertfordshire.